FIAPR. So, Dr. Iyer will talk about this orofacial pain today. Dr. Iyer, please, my pleasure to invite you to start your presentation, please.
Um, Good evening to all of you.
Good evening.
Good evening to all the ISSP, IAPM office bearers. Um, Good evening, Dr. Dr. Ashu was my examiner when I took the IAPM exam,
Thank
and
you. Thank
he
you.
he asked me a very difficult question. He was sitting with for one of the trigeminal stations, and he asked me a very difficult question. I don't know the answer to which today also, right? So, I can't remember what the question was, but I think I did about 2 years of research and I still don't find the answer to that. So,
सर गलत बात ऐसा डिफिकल्ट सवाल नहीं पूछ लिया.
so I will, in the next hopefully 45 minutes, we will try discussing as many conditions possible. We'll lay special emphasis on a couple of conditions that Dr. Ashu spoke about. And some of what I say may be very familiar. Some of what I say may have been taught by previous teachers, but it will be a good revision just in case I'm having a little bit of overlap with other conditions. So yeah, my no major disclaimers. I have no conflict of interest, and it is sorry. It's always a pleasure to be back at ISSP doing what I love the most, which is teaching. All of you know this. This is a very popular dish in Maharashtra. In fact, all over the world, all over India rather. And all of you know this is bel puri. Now, what is bel puri got to do with orofacial pain? Apart from the fact that you have to use your mouth a lot to bite it and chew it and enjoy the taste, um, orofacial pain, deciphering orofacial pain is like deciphering the contents of the bel puri, right? Too many things. You don't know what is it that is coming through. You're not sure. Sometimes when you bite the onion, the peanut comes along with that. The puffed rice shows up in between. So orofacial pain, deciphering it is like trying to figure out what's happening inside the bel puri. So the trick is you just enjoy the bel puri. Having said that, orofacial pain is not something very enjoyable, right? So what it is? So basically, it is a pain that is originating from regions of the face and mouth. And like you all know, there are multiple structures with complex vasculatures, and more so, the innervation of these structures are also very complex. And one of the major reasons why most of our patients are not able to clearly tell us exactly where the pain is coming from, what they just put their hand on their face, and it's up to you to kind of decipher what is happening, where it's happening. um, the first responders to orofacial pain are usually dentists, whether or not the pain is coming in from the orthostomognatic system. But usually the patients will go to a dentist, have a couple of teeth extracted. If they are very unlucky, the entire set of teeth. And then if they're still having pain, then the dentist is a little nice and sensible. He will then refer it to another, either neurologist or a pain physician. From there is where we get to see most of our patients. Now, the point that I was trying to make is with regards to the trigeminal ganglion. Now, the trigeminal ganglion is responsible for all sorts of pain conduction within the face. Okay. Whether you have pain coming in from the trigeminal nerve or the branches of the trigeminal nerve in itself, whether coming in from the muscles of the face, whether it's coming in from the joints in the face, the temporomandibular joints. The trigeminal ganglion is probably one of the epicenters for managing and propagating this orofacial pain. So we should know a little bit about this pathway, the which is the trigeminocephalic pathway, and I don't have much to say. The figure is very self-explanatory. But it is and this is the reason why many a times when nothing works, we look at ablation of the trigeminal nerve or one of its branches in the management of I won't say ablation, but targeting the trigeminal nerve or one of its branches when we are looking to deal or look at managing these patients with chronic orofacial pain. Many times we don't know the exact cause for. So, according to the International Association of Orofacial Pain, there are six major causes or classification for orofacial pain. First is basically because of dental and dental related issues. Nothing much to be spoken about. It is basically either from some form of inflammation of the dentine, which is the part under the crown, and the underlying pulp, which gets inflamed, infected, and this can cause irritation of the nerve. There is inflammation there, irritation of the nerve, and worst case scenario, it can even spread to the underlying bone. Myofascial orofacial pain, I think, is a very, very important and extensive topic. I can talk for 1 hour on myofascial pain because many a times you will find that the myofascial pain is probably one of the most important reasons for patients with chronic orofacial pain. I'm sure, I don't know if the class has been taken. I saw one of the classes was on myofascial pain, but yeah, we won't be able to cover myofascial pain today. TM joint pain is something that we will talk about, that is pain arising from the TM temporomandibular joint. And we will talk about any pain that is associated with either a lesion or disease of the cranial nerves. Mm, Most commonly, it will be the trigeminal and the glossopharyngeal nerve. The other types of facial pain are resembling that of headaches, psychosomatic or psychosocial orofacial pain, and when you don't know what the cause is and the patient's condition is very pathetic, we call it idiopathic orofacial pain. So, coming to the first talk for today, which is on temporomandibular joint pain. As we all know, temporomandibular joint is a complex hinge joint which is occurring between the mandible and the glenoid fossa of the temporal bone. In between that, there is an articular cartilage. There are ligaments around the TM joint, and there are muscles that move the TM joint. Now, when you talk of TM joint disorder, there could be a problem with either the anatomy or the function of the temporomandibular joint. Okay, so you could have had problems both, right? Similar to you have SI joint, sometimes you don't have SI joint pathologies, but you definitely can have SI joint dysfunction being a cause for pain. Similarly, with the temporomandibular joint. What are the contributory factors? Improper dentition, chronic clenching of the teeth, any form of muscular issue, that's where the myofascial pain comes in, and any pathology of the joint in itself, and is one of the most important causes for sorry, for non-odontogenic orofacial pain. Its prevalence is about 12%, and like most myofascial pains, more common in women. And it has significant physical, psychosocial, and socio-economic burden. Now, what are the before the advent of the early century this year, the cause for temporomandibular joint was believed to be malocclusion. But towards the late 1990s, they showed that the malocclusion has no role or minimal role, and therefore there is no role for orthodontic surgery. So patients with TM joint pain are not recommended to undergo orthodontic surgery anymore. Between 2000 and 2010, the the focus shifted on treating this aggressively in the form of doing invasive procedures. But again, systematic reviews showed that there was very poor evidence. From 2010 onwards, the focus of managing this has moved on from a very biomedical to a biopsychosocial approach. And this has resulted in use of behavioral therapy, which has proved to be cost effective, and the emphasis on combination of physical, psychological, and pharmacological management. Now, the etiology, like I said before, is multifactorial. One of the most common symptoms that patient comes to us with TM joint disorder is pain. The others are clicking, trismus, and chewing difficulty. The areas affected could be the one near the ears, around the eyes, throat, neck pain, facial pain, and even headaches. If you look at the physical factors in itself, there are two major physical factors. One is an inflammatory arthritis, like that which can happen with, let's say, ankylosing spondylitis or any inflammatory disorder, or a disc dysfunction, which can take place similar to how we have lumbar disc dysfunction. Now, if you look back at the slide on the trigeminal nerve and the root cause for all pathology being going through the trigeminal nerve, the TM joint pain afferents also go through the trigeminal nerve. Then there are also other activation inputs that come in from the meninges, from the tissues, and from the oral tissues and from the muscles of mastication. And there are, because of these wide conversion of inputs, there is therefore a very poor location of TM joint pain, and also the fact that it is very deep. It's not a very superficial joint that patients are able to put their finger and tell us. Now, how do you manage this pain? So, your basic aim should be alleviating signs and symptoms. There are various interventions that have been evaluated in relation to alleviating pain. But I think, like I said before, the conservative options have kind of shown to be more effective and have resulted in more satisfactory outcomes. So conservative strategies include medication, physiotherapy, use of occlusal splint, and use of cognitive behavioral therapy. Pharmacology, NSAIDs are the most common drugs that we use for management of TM joint pain. You can also use muscle relaxants, anxiolytic, opiates, not really recommended. TCS and gabapentin, I think now form are part of our prescription. Again, work more on neuromodulating pain rather than treating the pain in itself. And you must tell your patients that one dose or taking it for 5 days, like a course of antibiotic, is going to do no good. So long term treatment is definitely required. You can also use topical NSAIDs if you want to avoid too much of systemic absorption. What is the role of injections? Now, like the knee joint, over the last maybe 7 to 8 years, various substances have been tried. PRPs, corticosteroid, hyaluronic acid, dextrose. There is a little bit of interest in Botox, but again, Botox mainly for the muscles of mastication when there is a more myofascial component. Of the lot, steroids are very useful if there is an inflammatory component, which you can definitely make out by doing an MRI. But steroids are short lasting, give short lasting relief, and the studies have shown that the relief with steroids is maximum for about a week to maybe 10 days. For long term improvement, two particular uh, substances have been shown to relieve. One is use of hyaluronic acid, and the other one is platelet rich plasma. We'll talk a little bit about it in the next slide. And they have an anti inflammatory effect on the joint, improves joint lubricant, and it also dilutes your inflammatory substances. Like most other joint injections, use of ultrasound guidance is recommended. But please understand that the maximum volume that you can inject into the TM joint is about 1.5 to 2 cc. Anything more than that, you are risking a rupture of the capsule. So when it comes to an ultrasound guided injection, we use a linear probe. I would keep it in the long axis of the temporomandibular joint, just anterior to the tragus. And when you put your probe there, you will be able to see two bony structures. The lower will be the mandibular condyle, and the upper one will be the glenoid fossa of the temporal bone. If you want to be clear, you ask the patient to slightly open the mouth when the mandibular condyle moves downwards and the cartilage, that is the articular cartilage, will be shown up in between. An injection is usually done, preferred to be in the in-plane approach, starting from below, going upwards. And please take care not to inject into the articular cartilage. So what you can do is you can stay close to the mandibular condyle, go under the articular cartilage and give your drug. You can ask the patient to keep the mouth open during the injection, which will open up the temporomandibular joint space. Please use all aseptic precautions like you do for knee. This is also a joint. So please use all the aseptic precautions when you are doing TM joint injections. Now, coming to the role of PRP and hyaluronic acid. Now, multiple studies have come out in the last 5 to 6 years on the role of PRP. So, I think beyond doubt, it has proven that PRP is very useful for long-term pain relief of temporomandibular joint disorders. And it's always good to combine it with a little bit of hyaluronic acid, and therefore the combination is comparatively better than either one alone. The effect is long lasting, can last even up to 6 months, and if the patient does come back to you, you can always repeat it without much of an issue. Comparing it to an arthrocentesis where you put in a needle and aspirate the contents of the joint, arthrocentesis was widely performed in the early 2000s, but now they find that there is no significant use of doing an arthrocentesis. So PRP with a hyaluronic acid is any day better in the treatment of TM joint disorder than doing an arthrocentesis. The other option is an arthroscopy. I'm not sure of too many people who do a TM joint arthroscopy. Dental management for any caries is one potential therapeutic option. Splint therapy and occlusion therapy do work well. In fact, all our patients with TM joint, we first send them for a dental evaluation and we get them to have the occlusion splints put in. And if they do have bruxism, we start treating the bruxism first. And we perform interventions only if they have failed most of these conventional therapies. And by a time frame, I look at a minimum of 3 to 6 months, if beyond which I consider interventions. So these occlusion splints are very useful in kind of reducing the load on the joint and also improving the myofascial component, thereby giving you significant relief of the pain from the temporomandibular joint. Physical therapy, very important. You must have refer them to a physiotherapist who does a lot of orofacial physical therapy. They can do manual therapy, therapeutic exercises, where they do joint mobilization and soft tissue release techniques. And there is definitely therapeutic exercise. First thing I always tell my patients with TM joint, learn to chew gum for at least 1.5 to 2 hours a day. So it's a very good exercise for your muscles of mastication. One of the things that my physio also told me, and therefore I've added it here, is exercise for stabilizing cervical muscle, because poor posture also contributes to the myofascial component of the temporomandibular joint pain. So stabilizing cervical muscles and a combination of manual therapy and exercise gives better result than either one alone. And dry needling and acupuncture, very useful again, but very useful for only short-term pain relief. Electrotherapy, low-level laser therapy, all these are very, very useful and can be tried without much harm. One very important thing in patients with TMJ is the role of cognitive behavioral therapy. Okay, because it does teach them to manage their thoughts, behaviors, and feelings. So, a role of a psychologist, very, very important, and it's better that he's part of the multidisciplinary team with you, the dentist, and the psychologist, forming a team to treat such patients. It is always a role for education and self-management strategies, more useful in patients with typical myofascial disorders. And you can teach them relaxation technique, which again reduces muscle tension and stress. So that's as far as TM joint is concerned. we will proceed to the next segment, which is rather a more common and a more important topic, which is trigeminal neuralgia, also called a stick Dolorux or invisible disease. Now, trigeminal neuralgia, as we all know, is also called the suicide disease. There are multiple names for trigeminal neuralgia, and is probably one of the most painful conditions ever known to mankind. As all of you know, very famous film star also suffered from trigeminal neuralgia till he got treated. And you can mention in the chat box who that film star is if you know. I'm sure in a lot of podcasts and memes that are being circulated, yeah, the name of the film star is somebody has mentioned. Let me see what they have to say. Come on. Okay, somebody said, okay, all of you all have said Salman Khan. Very good. Santoshi Lakshmi, Sitara, all Bollywood buffs here. Great. Yes. So it is Salman Khan. Thank you for being so attentive. Um, that's nice to know. So, yeah, so basically, what happens in trigeminal neuralgia is there is recurrent unilateral brief episodes of facial pain which are characteristically described as paroxysmal, electric, or shock like stabbing pain attacks which are confined to one or more branches of the trigeminal nerve. It is sharp in initiation and sharp in termination with a projected lifetime prevalence of 0.3%. Now, the very important component of trigeminal neuralgia is something called refractory period. Now, what is refractory period is the period between two attacks of trigeminal neuralgia, two spikes of pain attacks, is called the refractory period. Okay. Now, this refractory period can be uh, it can be in seconds or it can be minutes, during which further attacks cannot be provoked. So, whenever you're taking a history of a patient with facial pain, if you are suspecting trigeminal neuralgia, this is one of the very important histories that you have to take. Is whether this patient has any pain free period between two episodes of the facial pain. Very, 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 very important. You must ask them if they say pain is continuous, you could still have trigeminal neuralgia, but that does not now become neuralgia. It kind of becomes a neuropathy, and therefore the treatment is completely different. Now we have three ways of classifying trigeminal neuralgia. It is idiopathic trigeminal neuralgia, classical trigeminal neuralgia, and secondary trigeminal. Idiopathic trigeminal neuralgia is when there is no cause, right? You have done all the investigations, you have evaluated this guy and or woman, but there is no cause. Classical is when on the MRI you are able to demonstrate a neurovascular conflict either at the root entry zone or slightly distal to that. Okay, that is up to the cisternal segment. Now, you have to be able to show that there is neurovascular conflict and not merely contact. And when there is a neurovascular conflict, there will be morphological changes in the trigeminal root. Now, if you speak to any of your radiologists, they will tell you there are 4 grades of contact of the vessel with the root. And we'll not get there, but please ask your radiologist what those 4 grades are. This classical trigeminal neuralgia can be either presenting as a paroxysm of pain, that means intermittent pain, or it can have a continuous background pain with intermittent spikes. Okay. The usual culprits of conflict are either the superior cerebellar artery, the anterior inferior cerebellar artery, the vertebral artery, and the petrosal vein. Now, it's very important that you know this order because the prognosis is also dependent on what the conflict is. So, if you speak to a neurosurgeon, they are very happy to do MVDs if the conflict is between the superior cerebellar artery or even the AICA. But if it's a vertebral artery, they are also a little scared. They don't want to do, okay, because handling the vertebral artery can be a problem. Two, somehow the results after MVD, even after a successful, even if they do a successful MVD, the patient do come back to us much earlier with recurrent pain. This is something that most neurosurgeons who do a lot of MVD will tell you that they're very happy to do MVD for the superior cerebellar artery, okay, where the compression is from the SCA. But when it comes to petrosal vein or this would be a vertebral artery, they are not really very happy, and the outcomes also are not very great. Now the secondary causes of trigeminal neuralgia is where there is another cause, and more often than not, the cause is some form of demyelination. And one of the very classical examples of a systemic demyelinating disorder is called multiple sclerosis. There could be other causes for secondary trigeminal neuralgia in the form of a tumor compressing the trigeminal nerve at the root. So that can be a cause. Could be trauma, multiple other causes for trigeminal nerve compression. Now, whenever you have, so if you look at the ICD-10 classification, trigeminal neuralgia comes under something called trigeminal autonomic cephalalgias, TACs. Okay. Now, two other entities that come under this TAC, apart from trigeminal neuralgia, are something called SUNCT or SUNA. SUNCT is short-lasting unilateral neuralgiform headache attacks with conjunctival tearing. Okay. And SUNA is short-lasting unilateral neuralgiform attacks with some form of autonomic symptoms. Usually, SUNCT and SUNA will have a V1 presentation, whereas trigeminal will have more of a V2, V3 rather than a V1 presentation. The severity of pain is very bad in both of them. But if you carefully tease your patient's history, he will tell you that in trigeminal neuralgia, the duration of attack is about 1 second to about 1.5 to 2 minutes. Whereas the SUNCT, SUNA headache, facial pains can last you anywhere up to 5 to even 10 minutes. Okay. Usually, trigeminal neuralgia will not have any autonomic features, whereas SUNCT SUNA will have some form of autonomic features in the form of conjunctival reddening, conjunctival tearing, nasal, some form of rhinorrhea, bradycardia, some form of autonomic dysfunction will definitely be there. The chances of having a spontaneous attack only, that is without a trigger, okay, are 40% with a SUNCT SUNA. And usually trigeminal neuralgia is triggered off by something in the form of brushing, wind blowing on the face. Okay, so spontaneous episodes are higher with SUNCT SUNA. A refractory period is classically present in trigeminal neuralgia, not so classical in SUNCT SUNA. And the drug of choice for treatment for SUNCT SUNA is essentially lamotrigine, and for trigeminal neuralgia is, we all know, is carbamazepine or its derivatives. Now, what really happens in trigeminal neuralgia, whether you call it idiopathic, whether you call it classical or secondary, is essentially some form of demyelination. So whenever there is demyelination of the trigeminal nerve, the trigeminal neurons, so the myelin sheath is responsible for keeping the conduction of the nerve in order. So whenever there is a loss of this myelin sheath, the orderly passage of action potentials is disturbed, and there is excess firing in the areas where there is lack of myelin sheath. This constant firing creates some form of peripheral and central sensitization, which can be triggered off by innocuous stimulus and a very lower threshold according to the individual. So this will result in epileptic-like discharges, which are painful, evoke paroxysms. And over a period of time, if there is central sensitization, there is prolonged spontaneous pain or even recurrences after surgery. Clinical features. trigeminal neuralgia is more commonly seen on the right than on the left. The logic being that the foramen rotundum is smaller on the ovale. The rotundum and ovale are smaller than on the right side than on the left. Unfortunately, females are more affected than men. Like I told you before, V2, V3 is more common than V1, and a combination of V2, V3 is more common than V2 and V1. More often seen in elderly, not that young patients don't come with trigeminal neuralgia, but yeah, it's generally a disease where it is over 50 years. And stabbing paroxysmal pain is the first symptom in about 87% of patients. You will have to take the history of a pain-free interval. And usually patients with trigeminal neuralgia sleep well at night. They don't wake up in the night with pain. Okay. And the triggers are innocuous facial stimuli like shaving, touching face, eating, drinking, brushing teeth, talking, makeup, sneeze, washing your face, fan blowing on the face. All these are very, very, very common triggers of trigeminal neuralgia. Okay. And these zones, they have specific trigger zones like mentioned here. So, depending upon the area involved, you will have pain in that particular segment. Now, remember that the diagnosis of trigeminal neuralgia is a clinical diagnosis. Okay. So, when a patient sits in front of you, you are able to make this diagnosis, you are able to take out this history, and then you label the patient as having trigeminal neuralgia. Okay. There is no blood test that defines trigeminal neuralgia. An MRI is corroborative for trigeminal neuralgia, but it is not proof of having trigeminal neuralgia. Okay, when you're able to elicit the pathognomonic history of a triggered paroxysmal pain, which you will be able to do in 95 to 99% of the patients, you have made a correct diagnosis of trigeminal neuralgia. Of course, when there is demyelination, when there is an underlying demyelinating disorder, you will have other features. For example, in patients with multiple sclerosis, you will have bilateral trigeminal neuralgia. You will have bilateral facial pain. There will be other features of multiple sclerosis in the form of weakness, autonomic disturbances like bladder issues, bowel issues, and it is generally seen in much younger patients, right? And you have to rule out if you in so my fellowship, when I was doing my fellowship in Singapore, my teacher would tell me that every patient who comes to you with a facial pain and you think it's trigeminal neuralgia, please do an MRI, and we'll know why we have to do a trigeminal MRI, right? Now, the reason why we do an MRI is A, we rule out any space occupying lesion. Two, we definitely rule out multiple sclerosis or other demyelinating disorders which had to be treated on a priority, right? If there is a neurovascular conflict, it's not a priority to treat it. But if the patient, if the MRI does show tumor, it then becomes a priority to treat it. If the MRI shows evidence of demyelination, then that has to be treated on a priority, right? You have to give steroids, IVIG, and there are other medicines to treat demyelinating disorders. So that has to be treated on priority. If there is a neurovascular conflict, again, depending upon the grade of the neurovascular conflict, depending upon the age of the patient, you can then decide what sort of management strategy you want to adopt. But I think as a baseline, you must do an MRI in any patient whom you're seeing with trigeminal neuralgia. Coming to treatment, so the treatment we all know has non-pharmacological and pharmacological arms. And non-pharmacological could be either non-invasive, minimal invasive, or a microvascular decompression. Now, depending upon what the type of trigeminal neuralgia is, the cornerstone for treatment of trigeminal neuralgia is use of pharmacological agent, and carbamazepine is the drug of choice. When I say carbamazepine, I'm meaning carbamazepine and its analogs. Sorry. Okay, derivatives. So first line of management is always pharmacological. Of course, if there is an intracranial space occupying tumor which is compressing, yes, then that will go in for a surgery if required, right? Now, if there is no tumor and we do find evidence of demyelinating disorders, then yes, that's a separate arm in itself. Now, if there is a neurovascular conflict of higher grade, grade 3 and above, then you must offer the patient a microvascular decompression, uh, because the best chance of pain relief is with MBD. They say the relief is as high as 70% for a period of over 20 years, right? So, young patient presenting to you with neurovascular conflict, documented neurovascular conflict, he should be offered MBD as the first line of therapy. Other options, when MBD is not an option, or MBD is not, you know, I mean, cannot be done, is then looking at various uh, non-invasive or semi-invasive therapies, which we'll go ahead. But a very interesting case report that I found is with the use of lidocaine and magnesium for intractable trigeminal. So again, one of the things that we do use in patients with Sangsuna is use of IV lidocaine in a dose of 4 to 5 milligram per kg body weight. You run it as an IV infusion along with 1 to 2 grams of magnesium sulfate, and it does provide very good, at least short term pain relief, lasting you maybe a day or two, but the pain does come back, right? So, treatment for Sangsuna is actually IV lidocaine, and long term pain relief can be given with lamotrigine. Now, I really don't have the time to go into extensive pharmacotherapy, but we all know that the drug of choice for treating trigeminal neuralgia is carbamazepine and its derivatives. So you have first generation, which is carbamazepine, second generation oxcarbamazepine, and now you also have eslicarbazine, which is third generation, right? Carbamazepine is a sodium channel blocker, and most sodium channel blockers are first line therapies for trigeminal neuralgia. In contrast, second line therapies like gabapentin, pregabalin, which are calcium channel blockers, for some reason do not work very well in this sort of neuropathic pain. In most other neuropathic pains and conditions, we give gabapentin and pregabalin, which are calcium channel blockers. But in trigeminal neuralgia, the role of sodium channel blockers is much higher. We don't know the reason why. Maybe there is greater upregulation of sodium channels in patients with trigeminal neuralgia. Therefore, sodium channel blockers are effective. One of the other drugs that we do use is a drug called lacosamide, which is not mentioned in the slide, and that works very well. Lacosamide again is a sodium channel blocker and can be used with starting dose of 50 milligrams going up to 200 milligrams. The only problem with lacosamide is you must be careful that if they do have a conduction defect in the heart, you must do an ECG, and if they do have a conduction defect, please don't prescribe lacosamide, right? It can worsen the conduction defect. Third line drugs are generally the baclofen. Lamotrigine is found to be a second line drug now, but I would suggest that if the patient is non responsive to any of these medications, please get a neurologist involved. And when it comes to starting drugs like lamotrigine or phosphonatoin, they are better at handling it. Opioids are somehow not favored, and in fact are much down in the scheme of things for management of trigeminal neuralgia. They are not ideal drugs to be given, and in fact they found very low level of evidence. Another drug that works very well is baclofen. Again, baclofen is second line drug for treatment. So how does baclofen work? It reduces the muscle spasms that can happen in periods of acute trigeminal neuralgia. But yeah, the only problem with baclofen is it can sedate you, and you cannot abruptly stop the baclofen. You have to taper it and stop. Okay, otherwise there'll be a risk of withdrawal similar to what you get with alcohol withdrawal. Now, in when I was training back in Singapore, whenever we had to prescribe a patient on carbamazepine, we had to mandatorily conduct this test, which is a HLA-B1502. Okay, so this is an allele that, if found positive in patients, they were found to have a very high risk of developing a very dangerous complication with carbamazepine called Steven-Johnson syndrome. Okay, Steven-Johnson syndrome is basically a severe anaphylactic reaction that can take place uh, in patients who are predisposed to it. So ideally, before you start any patient on carbamazepine, you must get this done. And this there has unfortunately not many studies done on Indian patients, but on Southeast Asian patients in the belt between, let's say, Pakistan to down to maybe Singapore, Indonesia, Malaysia. The risk of the HLA-B1502 allele being positive or present is very high, and therefore they should be extensively screened for this allele before you start. So we could not write carbamazepine unless we did this test for patients. Here, of course, I I I have known very few labs in India which test for 1502 allele. So yeah, but and also it's an expensive option. But there, because the incidence of SJ Steven-Johnson syndrome was so high, and a lot of people expressing this allele, they would. It was a very affordable test back then. The other side effect of carbamazepine is hyponatremia, and one must be careful to monitor serum sodium levels. A very rare complication of carbamazepine again is agranulocytosis. Fortunately, we don't see too many patients, but yes, once in every 3 months, it's always better to get a total count and serum sodium levels done in patients who are on long-term carbamazepine. The risk is much lower with oxcarbamazepine. The risk of Steven-Johnson syndrome is much lower with oxcarbamazepine, even lower with eslicarbazine. And the risk of hyponatremia was also found to be lower in the second and third line derivatives of carbamazepine. MVD, I'm not going into details, is basically where you're putting a gel foam between the artery and the compressed nerve. It's a major surgery. They do a retromastoid incision, and like I told you, the results are best with MVD. There is also an option of stereotactic radiosurgery where they use gamma knife, where focused gamma radiations are given with the help of a radiotherapist at the root entry of the trigeminal nerve in a dose anywhere between 70 to 100 grays. But the problem is there is no immediate pain relief. It takes close to 2 months for the pain relief to come. And if your radiation moves 1 millimeter this way, that way, you are likely to damage the pons. One of the things that we can do, one of the very common procedures done is radiofrequency ablation, where we are using thermal energy to denervate these pain fibers. And the success rate initially is as high as 95 to 98%. This is done with fluoroscopic guidance and patient under sedation. Please, when you do these procedures, please tell your patient that you're not taking away the pain, but you're replacing the pain with a sensation of numbness. Do not do radiofrequency ablation in patients with, sorry, in patients who have V1 neuralgia, because you can cause corneal anesthesia and therefore risking keratitis. Masticatory weakness and dysesthesias are potential complications of radiofrequency ablation, and the worst complication that you do not wish for any of, even your enemy, is a complication called anesthesia dolorosa. Okay. Now we all know that the trigeminal nerve is located, or the Gazerian ganglion is located in a part of your skull called the Meckel's cave, and this you can see in the figure. The three branches of the trigeminal nerve being the ophthalmic division coming out to the superior orbital fissure, the mandibular nerve, maxillary nerve coming out to the foramen rotundum, and the maxillary nerve that comes out through the foramen ovale. So our target for reaching the Gazerian ganglion is the Meckel's, is the foramen ovale. Now, another controversial topic is, what are you supposed to lesion? Are you supposed to lesion the nerve, or are you supposed to lesion the ganglia? Now, if you see multiple articles, all do mention that the best results of radiofrequency ablation are obtained if the ganglia is lesioned. and not the individual root, right? So whenever you do a radiofrequency ablation, please try to target the Gazerian ganglion, which is much deeper in the Meckel's cave and not necessarily one of the branches of the trigeminal nerve. So when you do these procedures, please have an anesthetic colleague at the head end helping you. Put an IV line, run a course of antibiotic. Do not do this in the OPD. Please do this with complete aseptic precautions in the operation theater. Have all your monitoring facilities in. Put an IV line, give an antibiotic, and please maintain complete asepsis. And one of the ways to do it is have a pillow underneath or a head ring under the head, and put a small pillow roll or a roll under the shoulder, and have the patient extend the head. And then you do something called an oblique submental view. In an oblique submental view, you are, depending upon which side, let's say you are doing a right sided intervention, you oblique the image intensifier caudally and to the same side as that of the intervention. So in this case, you can see Dr. Vikar, who's a very famous pain specialist in India and a good friend of mine. He is holding the patient's head. Any problems? Dr. Kashi? Okay. So he's holding the patient's head and
Bye.
kya hua?
You can mute them.
I can? Okay. I okay, sir. It's a little difficult for me to do it now. But anyway, yeah, and then you can. He's also obliquing the C arm to the right side, so you will get an oblique submental view. Now, what will you see in an oblique submental view? You will see the mandible, okay? You will see the maxilla, and in between the mandible and the maxilla, you will see an oval shaped opening, which is the foramen ovale. So remember that the foramen ovale is the only oval shaped opening at the at the bottom of the at the base of the skull, right? So you will clearly see the oval shaped opening there between the mandible and the maxilla, and do not, unless you see the foramen ovale, do not proceed to the next step. Now, the most difficult part of doing a radiofrequency ablation or any procedures of the trigeminal nerve is to identify the foramen ovale. So please spend as much time locating the foramen ovale. You should be able to see it obliquely, ovally, okay, between the maxilla and the mandible. You can use any of the RF needles that we use, typically the 20 gauge and the 22 gauge, which is the yellow and the black RF needles, are the ones that is commonly used for performing radiofrequency ablation. So once you have done that, you're painted draped, okay, you identify the foramen ovale, and using end on view, you pass the needle uh, into their foramen ovale. Now, question is, how should you pass it? If it is, so one conventional teaching was, if it is V3, pass it at the lateral aspect of the foramen. If you are going to V2, put it in the middle of the foramen. And if you are doing a V1, which is usually not done, you pass it to the medial aspect of the foramen. Now, my take on this is a little different. Given the natural curvature of the needle and the angle of the face, if you target your needle from the lateral aspect of the foramen, the natural curvature of the needle will take it medially, right? So, if you are doing a V3 ablation, don't necessarily have to target your needle at the lateral aspect of the foramen. You can even push it in the middle of the foramen and direct it a little laterally. Okay, so the needle passage, it used to be a very common saying to put it in the different aspects of the foramen depending upon what you are lesioning. But now we know that the needle can be moved to any part with just manipulation, and therefore it's not a must rule to stick to this, putting it in the lateral aspect if you're doing a V3, and if you're doing a V1, put it on the medial aspect of the foramen. Typically, what I do is, if it is a V3, I would still put it somewhere between the outer one third and the middle one third of the foramen, and direct my needle a little laterally so that I am targeting the V3 division, right? And once you have reached a certain depth, uh, switch to a lateral view. Now, when you do a lateral view, it is very important to have a true lateral view. Now, what do I mean by true lateral view? You can see on the left side of the image, the mandibles are overlapping beautifully with each other. The maxilla again is overlapping with each other. The frontal bones are overlapping with each other. You can see one external acoustic meatus somewhere there, which is the the bright circular opening at the lower portion of the skull, and you can see a nice beautiful U-shaped pituitary fossa and the line that is joining it to the black portion of the bone. Now the black portion of the bone is called the petrous portion of the temporal bone, and that line that joins the pituitary fossa to the temporal bone is called the clivus. Now it is very important to know this anatomical landmark because the clivus decides which part of the ganglia you are likely to lesion. Now you can see in the left side of the image that I haven't really entered the foramen ovale. I'm quite a distance away. So under local anesthesia, I mean obviously you're doing all this under local anesthesia. You pass your needle. Now once you enter the foramen ovale, the patient will say he will feel a twitch, which is usually coming in because you have touched the mandibular nerve that comes out of the foramen ovale, and you know for sure that you have crossed the foramen ovale. Now, once you have reached the foramen ovale, depending upon what lesion you are trying to do, you are trying to do V3 or a V2 lesion, the tip of your needle has to be moved. Now, if you are doing a V3 lesion, then the needle tip should be somewhere within the middle half of the Meckel's cave. And that is where the ganglia or the portion of the Gezerian ganglion which is responsible for V3 sensation is located. If you are doing a V2 stimulation, if you're doing a V2 lesioning, then the needle should be passed a little more anteriorly and up to the clivus line, up to the clival line, to be able to ablate the V2 division of the Gezerian ganglion. And usually, when you reach this depth, in 95% of the patient, you will get a backflow of CSF, which you may not get sometimes in a V3 when you're doing a V3 lesion. If you are doing a V1, if you're doing a pulsed RF, then your needle goes 1 centimeter or 1 or 2 centimeters beyond the clival line, and that will give you a V1 stimulation. And once you are done there, you do a sensory stimulation. Usually, you should get a sensory stimulation between zero 0.3 to 0.5 volts. If you are getting it anywhere above that, then your needle is not near the nerve, and therefore you must redirect your needle. Uh, Generally, when you're doing a ganglia lesioning, you look at something called a sensory motor concordance. What is a sensory motor concordance? Is that you start getting motor stimulation. Now, when you're saying motor stimulation, you are, let's say I'm doing a V3 lesion. Okay. For a V3, the sensory will come on the lower aspect of the jaw, and the motor stimulation will come with masseter contraction. Okay. Now, if you're on the nerve root, if you get sensory at 0.1 or 0.2, in fact, you shouldn't do if you're on 0.1 because you're on the nerve. Let's say you get sensory at 0.2, your motor will also come at 0.2. Okay. But if you are on the ganglia, you will get motor 2 times that of sensory, which means you'll start getting masseter twitches at around 0.3 to 0.4 volts. Okay. So this is called a sensory motor concordance. If you're doing a maxillary, that is a V2 lesion, we don't worry too much about motor twitches because inevitably you will get it because the needle is traversing on the ganglia to reach the maxillary division of the Gezerian ganglia. So it's okay to do it, but yeah, inevitably look at sensory stimulation occurring at that level. Now, once you have done that, you take out your stillet. If you are getting CSF, then you proceed with you put a thermocouple probe and proceed with lesioning. If you are not getting CSF, then you can give a little bit of preservative free lidocaine, 1%, 0.2 ml, and then ask your anesthetic colleague to sedate him or her with a little propofol, and then you can do about 3 or 4 lesions. So I typically do 3 lesions, one at 50 degrees at 75 for 75 seconds, second one at 60 degrees, and the third one at 75 degrees. Do not exceed more than 80 degrees because that can char the nerve and create more complications. And there is definitely very poor evidence for doing pulsed RF of the Gazerian ganglion. However, you can do it in patients with postherpetic neuralgia, especially if they have a V1 involvement. The other procedure is balloon compression. Okay. And what we are doing in balloon compression is ischemic ablation or destruction of the Gazerian ganglion. And the idea is that you are only damaging the A delta and C fibers, which are responsible for conduction of pain, and preserving the A beta fibers, which are responsible for proprioception and touch. So therefore, the sensation of corneal anesthesia is not a complication. So therefore, very useful for V1 neuralgia, but it needs general anesthesia. Very low risk of corneal anesthesia, but one definite complication is masticatory weakness, but it's self-limiting. The only problem with a balloon compression is the outcome is dependent on the shape of the balloon. So we have several kits in the market. This is one of them. Basically, the kit will contain a 14 gauge cannula, a dilator, okay. Sometimes it contains a needle, and then it contains a Fogarty embolectomy catheter, which is usually 4 French. Okay. So it's a small video on how we do a balloon compression. Sorry. Okay, so the first step is under GA, aseptic precautions, antibiotic, fluids, whatever. Identify the foramen ovale on a submental view. Okay. And once you have identified the foramen ovale on the submental view, target the inferior and lateral aspect of the foramen and place this 14 gauge cannula after giving a little bit of lignocaine and adrenaline, okay, on submental view to get an end-on appearance, okay. And once you have done that, you have got a good end-on appearance, okay. And your target should be the lower border of the foramen, okay. And I'll tell you why we have to target the lower border of the foramen, okay. And then take an AP view, following which you go to take a lateral view. And in the lateral view, we see that the tip has not reached the foramen ovale. Now, you must understand that the cannula should not pass beyond the foramen ovale, otherwise it can cause dangerous bleeding. So you take the cannula up to the foramen ovale, and through the cannula, you pass a small dilator, which can go up to the clival line, right? Yeah, so you put a small dilator that goes through this up to the clivus. I'm just going to run through this video, right? Yeah, so you can see the dilator going up to the clival line, right? The next step is to remove the clivus, and then you put a 4 French Fogarty catheter, and ensuring that the tip lies just beyond the clivus, okay? And I will tell you why we should have it. So you can see the tip line just about a millimeter beyond the clival line. And once you do that, under live fluoroscopy, you will take 0.7 cc of contrast and inflate the balloon. Okay. Do not take more than 0.7 cc of contrast because that will cause rupture of the balloon. And you can see a nice, beautiful pear-shaped balloon with a small tail that is extending posteriorly. This you can keep for anywhere between 90 to 120 seconds. And once you have done that, deflate the balloon and remove the whole thing en masse, that is the needle and the Fogarty catheter. Don't try removing the Fogarty catheter and then remove the needle. You will cause a breakage of the catheter. Okay. So remove the whole thing en masse, and then the patient can be extubated. During this procedure, especially when you're doing a compression, patient can have dangerous bradycardia. So keep your anesthetist informed about possibly needing a little bit of IV atropine. Now, we said that the outcome is dependent on the shape of the balloon. So there are 4 shapes of the balloon. I'm sorry I have exceeded time. I'm hoping to finish in the next 15 minutes. Dr. Ashu, Dr. Prakash, and Dr. Kashi, apologies for the delay. I will finish this in the next 10-15 minutes.
It's okay, you continue.
So there are four shapes of the balloon. One is a pear shape, one is dumbbell shape, one is cylindrical, and one is the oval shape. The best outcomes are seen when you get a pear shape. Okay, so this is pear, this is dumbbell, this is oval, and the last one is cylindrical. Now, why do we get a pear shape of the balloon? Is that the tip of the balloon sits beyond the Meckel's scale in a portion of the bone called as porous trigemini, PT, that you can see here, right? And that will cause optimal compression of the trigeminal ganglion, thereby giving you the classical pear shape. Okay, so this is again one of the reasons why we choose the inferior border of the foramen. Okay, so when you put the needle in the inferior border of the foramen, the natural passage, the natural angulation of the face takes the catheter to a more medial direction, resulting in what we getting a pear shape. Okay, or rather, take if you pass it in the upper border of the foramen. Sorry, in this image, if you put it in, if you see the needle, it's targeting the upper border of the foramen, right? And they at the upper border of the foramen and upper and lateral border of the foramen, when you target it there, the natural course of the balloon goes laterally, and that's where you get an oval or pear shape. Whereas if you target your needle to the inferior and slightly medial border of the foramen, then the natural curvature of the face and the base of skull make sure that your needle is right over the Gazarian ganglion, and therefore you will get this pear shape of the balloon. Now, this is something that I think we've spoken about. We said that the best results are for long-term follow-up. By long-term, I mean more than 10 years is with MVD. But balloon compression and radiofrequency thermocoagulation give excellent results, um, anywhere between 2 to 5 years, with a pain efficacy of close to 90%. Um, Complications, yes. Most commonly, you have the dysesthesias and the numbness with radiofrequency ablation and radio and balloon compression. The rest complications are actually very, very negligible. Masseter weakness is one complication that is there, but usually gets better with time. Now, when nothing works, you are looking at possible neuromodulation. And one of the ways to do it is stimulating the peripheral nerves of the trigeminal nerve. So you can put leads on any of those branches. So you can see two leads on the supratrochlear, supraorbital nerve, and on the infraorbital nerve. And this can be connected to a programmable generator. And there's a very famous song in what was it was I always thought it was लावारिस, but it is sharabi, which is जिसका कोई नहीं उसका खुदा होता है यारों. So in this, when nothing fails, neuromodulation will definitely work, right? So mechanism, as we all know, is based on the gate control theory, and what we are trying to do is essentially do a field stimulation more than a nerve stimulation. And the only problem is it's cost prohibitive, but the results are promising. Now, the last 5-10 minutes will be on glossopharyngeal neuralgia. And can anyone tell me why this guy is pulling his ears? And what is the relation of this picture to glossopharyngeal neuralgia? It's one of the described techniques for pain relief in glossopharyngeal neuralgia, where you can pull your earlobe down, and it has been found as a very likely maneuver for relief in patients with glossopharyngeal neuralgia. Okay, so it's basically the neuralgia involving the ninth cranial nerve. Okay, occurring unilaterally in the distribution of the glossopharyngeal nerve. Okay, and like trigeminal neuralgia, you have again the idiopathic or the secondary causes where there is vascular compression, some form of demyelination, intraoral or extraoral pathologies. A very common complication is causes Eagle's syndrome or stylalgia, where there is elongation of the styloid process or the stylohyoid ligament calcification, causing compression of the glossopharyngeal nerve. Okay. Like trigeminal neuralgia, again, this will also have recurrent painful attacks in the distribution of the glossopharyngeal nerve unilaterally, lasting a few seconds to 2 minutes, with typical triggering features like trigeminal neuralgia. And usually seen in much younger patient. No significant prodromal symptoms, and the patients will report pain in the ear, epiglottis, pharynx, palatine tonsil, base of the tongue. Swallowing can make the pain worse. Hot and cold water both will aggravate. Because they don't eat, they will have weight loss. And unlike trigeminal neuralgia, glossopharyngeal neuralgia will have night pain. Now, trigeminal neuralgia usually is not life threatening, whereas glossopharyngeal neuralgia is life threatening because of the spillover of these impulses to the nucleus tractus solitarius of the vagus and up to the medulla, causing dangerous bradycardia. Okay, so glossopharyngealgia can be dangerous, can be life threatening, can cause dangerous bradycardia as well. Okay, and this is one of the case reports where they found that a patient with after an attack of glossopharyngeal neuralgia had sudden episodes of bradycardia and even a cardiac arrest. Right now, the workup is very similar to what you do for trigeminal neuralgia, but you also do an ENT examination to look for elongated styloid process. Okay, the drugs used again are much similar, sodium channel blockers. So use carbamazepine, lamotrigine, gabapentin, baclofen don't really work very well here, right? Don't use too much of NSAIDs, okay, and opioids again, not really very useful in these set of patients. Interventions, microvascular decompression is a procedure can be done, but again, not as commonly done as it is for trigeminal. Glossopharyngeal nerve block and ablation is one definitely treatable, doable procedure. Styloidectomy when you have a definite documented evidence of an elongated styloid process, right? So this is an MVD for the glossopharyngeal nerve. When you're doing a glossopharyngeal nerve block, you can do it either with fluoroscopy or ultrasound guidance. Fluoroscopy, your target is the styloid process. So you go hit the styloid process, give your drug, and if you can see a good spread of drug along the styloid process, then you give your drug, whether you want to give local steroid. I do use alcohol in patients with cancer related glossopharyngeal neuralgia, but otherwise we don't do too much of alcohol ablations here. Ultrasound has proved to be very effective, where you put your linear probe or curvilinear probe between the angle of the mandible and the mastoid, and in between the two bony prominences at around 2 to 2.5 centimeters, you will see the styloid process, and all you have to do is go down, hit the styloid process, just walk past it, and you can give your drug. You can also do a radiofrequency neuromodulation. Please do not do an ablation here. It will cause a complete paralysis of swallowing on that side, and you can even have aspiration. So pulse radiofrequency is the mode, and you have to do stimulation at 50 hertz, and the patient should feel the sensation near the pharynx, tonsil, middle ear, or even the posterior one third of the tongue. Remember, there are two major vessels there. One is the carotid, and the other one is the facial artery. So you can injure them. So please be very careful when you're doing this. Like I said, in this one, there could be hoarseness because of spillage of the drug to the recurrent laryngeal nerve. Okay, so be careful. Do not do bilateral glossopharyngeal nerve blocks, not this one. And the loss of parasympathetic outflow will then result in tachycardia and a slight hypertensive response. So watch out for these things, right? If there is a definite elongation of the styloid process, you can do a styloidectomy, and that has again shown to have very good results for treatment with glossopharyngeal neuralgia, right? So yeah, this is in effect the algorithm to manage patients with glossopharyngeal neuralgia. Pharmacotherapy is first line. If not responsive, you look at doing the interventions. Right. So with that, I come to an end of my talk. What I could not cover was dental pain, but I really don't know what to talk in dental pain, and so I've just given that a miss. If there is any doubt, I know, sorry, I exceeded the lecture time by around 15-20 minutes, but there are too many topics. So if there's any questions, I'll be more than happy to take it forward.
Oh, thank you, Dr. Iyer. Very elaborative and difficult topic, actually. And you summarized it very nicely. Actually, it's a huge topic, everything. So let us take the question first. How many times we can do RFA of trigeminal nerve?
So usually a well done trigeminal nerve will give you benefit anywhere between 2 to 5 years. But having said that, there is, if you're looking at the time gap between two radiofrequency ablation, it is said that you have to wait for a year before doing the next one, right? So yeah, so that's the first thing. But yeah, if you're looking at an overall number, I've had patients who come to me with 5 or 6 trigeminal RS being done, right? So I don't have a number for that, but between two episodes of RF, I think you have to wait for anywhere between 6 months to a year.
Yeah, anything around 6 month, because if the pain is coming less than that, that means either our treatment is not working or there is some other problem that we have to look
Pause.
into. So rather than jumping for doing it again, let us find out where the things went wrong. Like in one of my patient, we did V2 with the MRI report done outside, no films.
Hmm.
And patient has recurrence within 2 months. On repeat MRI, patient has maxillary sinus carcinoma tumor.
Hmm.
So this was not reported in earlier this thing. So like very early return. So you have to really look for other causes which are important rather than jumping for re doing again RFA. So which is important, right? So another question is मेरे को थोड़ा समझ नहीं आया sir. Please tell where exactly we need to hit at foramen ovale in order to enter inside. You explained it already beautifully. Where to hit at
So
foramen.
anywhere around the margins, if you hit and then you go upward or down, you will enter the foramen ovale.
Yes. So if you have a bend needle and you are hitting the bone margin, just rotate inside and you will go in. So this should not be a difficulty. Yes, this recording will be available. How do you mix PRP and hyaluronic acid? Yeah, you do a lot of PRP and hyaluronic acid, Dr. Iyer.
I
So
do, sir. I do it. I do a lot, but I don't mix them in the same syringe.
yes.
I do a
So
sequential
always we have to
injection.
give it separately now. We
Yeah.
don't mix
So
them.
it's sequential. So HA followed by PRP
Yes,
first.
yes. Okay. And as you told, if you are doing in TMJ, maybe how much hyaluronic acid you give?
Point 0.5
1 ml
to 0.5 to 1 ml.
maximum, right?
Maximum.
Yeah.
Doesn't take beyond that at all.
Hmm. Sir, could you please repeat sensory motor coordination for conventional RFA, which you told?
Okay.
Sensory motor coordination
So
for
it's sensory
conventional.
motor differentiation that we are talking about. So this is something that is done in order to differentiate whether your needle tip is on the root or on the ganglia, right? If
Yes.
you are on the ganglia, the the voltage at which you get sensory stimulation and the voltage at which you get motor stimulation will be in the ratio of 1:2, which means if you get sensory stimulation at point 0.2 and you're getting motor stimulation at point 0.4, this is called sensory motor differentiation. This is very classical of your needle tip being on the ganglia, not necessary in the trigeminal, even when you're doing a dorsal root ganglia lesioning or a
Hmm.
pulsed RF neuromodulation. If the if you're on the nerve root, you will get it the motor and sensory at the same voltage, which means point 0.1, point 0.2 sensory, point 0.2 motor. But if you are on the ganglia, then your motor will be 2 times the voltage required for sensory stimulation. So this is called sensory motor differentiation, which is ideally, which should ideally be done, and it's predictive of your needle being on the ganglia than on the nerve itself.
Yeah. So another question is steroid administration at the end of procedures to avoid neuritis
You
in
can
trigeminal
give needle. I
ganglion?
do. I give steroid. I give steroid at the end of the procedure.
So if you get CSF, we don't inject any.
Definitely don't give if you get CSF.
Yes.
Please don't
So
give local. Don't give steroid if you get
yes.
CSF.
So if you are doing V2 and V1, most of the time you can get CSF. So it
Yes.
is better to avoid giving
Avoid.
drug inside.
True. I
Doing
would
V3,
definitely
yes. Doing V3, you can give.
do true
That is
because
not.
sometimes in B3, even if you're on the ganglia, you don't get CSF.
Yes, yes. So if you invariably you are doing V2 and V1, many of the times you will get CSF. So it is better not to give
Not
anything inside
correct.
when once you get CSF.
Correct. Correct. Correct.
Okay, sir, you can point out the styloid process in ultrasound
I will
image.
send the image across. I don't have
Yes.
this one.
Actually, I was about to talk about this point.
Mm,
During fluoroscopy, since it's a fibrous structure, it is
mm,
very difficult sometimes to
correct.
see
Uh,
styloid process. I do lot of fluoroscopy.
mm,
Many of the times I can't see this
I
styloid
have
process. So it is always said that ultrasound imaging is much better than doing fluoroscopy.
true.
So kindly provide some images for their reference.
I will send it across to you, sir.
Yes,
Then you
yes.
can share it with them. Yeah.
Sir, can we do RFA of trigeminal ganglion if MRI reports as thinned out trigeminal nerve?
Thinned out trigeminal nerve usually will mean neurovascular conflict of grade 2 and above.
Hmm.
That also depends on what your patient profile is. If it's a young guy, then it is better that you subject him to. I would definitely recommend to undergo an MPD, because see, when you do an RF or a balloon, what you are doing when you do a heat lesioning or ischemic compression, you are scarring the nerve. In a young patient, when there is already some form of demyelination, neurovascular conflict happening at the level of the root entry zone, a scar on the nerve is not a good sign of long term pain relief. There is a possibility that he will come back because of, not necessarily because of the compression, because of the scar in itself, right? So I am a little wary about doing these neuroablative procedures in younger patients, right? But if your patient is elderly and not fit for surgery and is in the prime 80s, would you really want to subject that patient to a very very high risk surgery like an MPD? Not really. So it all depends on whether the profile of the patient that you are choosing, right? Having said that, I have done between the two evils, let's say between RF ablation and balloon compression. Of the two evils in younger patients, what would I choose? I would definitely choose a balloon compression because the ischemic damage to the nerve is much lower compared to the ablative thermal damage to the nerve, right? So, yeah, so that's the thing as far as um, that goes.
So
That more on
definitely with thinning and all this, it is better to go for MBD rather than.
MVD, I would agree. I would definitely agree that it means the morphologically the nerve has become so
Yes,
so compressed that not sure how much. See, if your idea is to give them 1 day, 2 days relief of pain or 1 month, 2 months relief of pain, go ahead
yes,
and do it.
yes.
But if you're looking at meaningful long-term pain relief, then I think you should be careful about choosing.
So the next question is, sir, do we need to have CSF flow for
B2, yes.
to?
Ideally, yes. Ideally,
So
yes.
most of the time, as we were talking, you will have
You will have.
CSF flow if it is nicely placed, but it is not necessary.
Not necessary. I agree. Ideally, yes, but not necessary.
How to treat differentiation pain after ablation? Very
Oh.
important question. At least at the end, somebody has asked.
Santoshi Lakshmi. Okay, so deafferentation is something that you shouldn't wish for even your worst enemy, right?
Hmm.
Very, very difficult to treat. In fact, the deafferentation pain is worse than the pain of trigeminal neuralgia. If you
Hmm.
if you see patients with deafferentation, they will tell you I was better off living with trigeminal neuralgia because that was at least episodic.
Yes, and it is a continuous burning pain.
This one is continuous burning, does not respond to whatever you do. There is no scope of intervention. But yes, you resort to pharmacotherapy as your first line therapy. Then now, all these while we were giving sodium channel blockers. Now our calcium channel blockers will start coming in. So you start giving them pregabalin, gabapentin, lamotrigine, phosphenitoin. You can use all the mirch masala that you want. Some people do pulsed RF of the Gazerian ganglion.
Hmm.
There have been isolated case reports of pulsed RF being slightly effective, but no real long-term cure.
No,
But
not a good thing to do
not a
again.
good, yeah, but doesn't work as well, right?
Yes, yes.
The
Any
only
role of steroid into this? If it is
If it
immediate.
is differentiation, no, sir. Even
No,
steroids
sir.
don't really have too much role. Because the pathology is that the neural damage has already taken place. It's gone beyond the stage of neuritis. It has gone into some form of significant nerve damage where a steroid may not help. Intravenous steroids can help, but local steroid
That has
deposition
to be immediately, na?
immediately. True,
Not after some time.
true. But the good thing about differentiation, at least in the trigeminal nerve, is not a very common complication compared to, let's say, you're lesioning the femoral cutaneous nerve of the thigh, and
Mm.
you're doing a thermal lesioning there. So in that
Then it
situation,
is a problem. Yes.
deafferentation is far more common, and patients will come back to you.
Because we are ablating a peripheral now, so chances of deaffrations are much, much high
Very,
as
very high.
compared to ablating a
Do
ganglion.
something in the trigeminal nerve. So yeah, so
Anyway, if we do ablate ganglion, deaffration pain is much
will
less
never happen. Will
to
never
that.
happen.
So these are the question. I wanted to highlight certain point for students because there are a lot of students here. So one thing is if you have trigeminal neuralgia secondary to multiple sclerosis, please don't jump for any interventions because it's a less self-limiting disease with the neurologist opinion and all this, and it has got jumping involvement of various cranial now. So you it can really land you into serious troubles later on when patient can have other nerve roots involved, and that will anyway cure by a neurologist. So uh, it is better to avoid interventions in multiple sclerosis patients. And then one very common mistake that I have seen that we find in referral patient, when you order MRI of the brain, don't write plain MRI plain. It you will always have to write MRI brain
This sequence,
trigeminal sequence, and you don't.
CISS sequence. Yeah.
Yes. Otherwise, you will not get the correct information, and you don't need to do contrast MRI to see this neurovascular conflict in this trigeminal sequence MRI. They comment very well. But if you have find other causes like multiple sclerosis or something, that's a separate issue. Then you may have to go for contrast, but not for your classical this thing. So please do write trigeminal sequence. Don't believe on plain MRI. You have to get it done again. Then we were talking about this role of carbamazepine as a first line drug. So if there is a very good article for students, phenotypic of neuropathic pain, where all excitatory pain have sodium channel blockers as a first line therapy, but it only exists in for examination of point of view in trigeminal neuralgia only. For CRPS and herpes, you don't, though they are in the same category, but you carbamazepine is not first choice of drug. Then for gamma knife, it is not a good treatment because the success rate is low as compared to your surgery level. As Dr. Iyer has said, 2 to 3 months of onset period, recurrence is high. And if you want to later on do surgery because of fibrosis after that, it can create a problem, and it's expensive. I tell you, around 3 4 lakhs job. So it's an expensive job. So results are not very good. So please, I think RFA and MVD are much better. And one thing that I would when I want to stress, Dr. Iyer was talking about hearing loss after MVD. Surgeons never, tell their patients about hearing loss. It can be a significant complication after MVD. So it is important. And for balloon compression, it is a non-selective technique. You can't target V1, V2, V3. It's not kind of that. So we have to keep in mind. And during doing RFA of glossopharyngeal, as we were talking about, it is involve lot of autonomic dysfunctions. So if you attempt doing conventional RFA, it can cause serious autonomic problem to your patient intraoperatively on bed. So please don't try to do conventional RFA. You have to always do PRF with everything ready because you can have serious autonomic problems, bradycardias, tachycardias during this. And we talked about this steroid process. So this is all a couple of points I want to stress from my side. I don't, we have some two more questions.
There was a role question on
Any role of stimulators? So you have already talked about this.
yeah. The
One
stimulators
thought.
for deafferentation, yes, that's what I said. जिसका कोई नहीं उसका खुदा होता है. Any pain you can treat with stimulator, but is stimulator a viable option? No, I mean at this point of time, at least in our country, we are far
Yes.
away from that.
And what is next question? What about
Stim
time
pod
mod?
stimulation and dry needling for TN. Yeah, I mean can do. There are no.
So
There
there are no established.
there is no evidence to prove
Dry
that.
needling, like you were talking in TMJ, if there is a, we have treated many patients with trigger point in Meseter, they are presenting to us with V3 division pain,
Correct.
and you can easily treat them with the dry needling with 2 or 3 sittings. So not for trigeminal neuralgia, for myofascial pain originating from either most commonly Meseter or temporalis muscles, but not for trigeminal neuralgia. And Steampo doesn't work. Company, this is a company-driven propaganda. Not you don't have a very effective role of this. So I think we are done with this. Any other Dr. Prakash, Dr. Kashi? Any
No,
comments?
बेल याद रहेगा.
Wonderful.
Yes.
I
Very
think
nice presentation.
Yes.
we are done with the presentation.
Yes. We are done with the presentation.
Thank you.
Any more questions?
One
No,
more.
no,
No,
no.
no.
Thank you very much, sir.
Wonderful.
Thank you very much.
Thank you. Thank you.
Thank you, sir.
Thank you,
Bye.
Yeah.
Ashu sir.
Thank you all.
Prakash
Yeah.
sir. Thank you, Dr.
Bye.
Kashi.
Yeah.
And
Bye.
thank you to all of you for a patient hearing. I know it's way past convert time, but I was
It's
trying
It's
to
okay.
complete
It is
as many
important.
topics as I possibly could, but these are definite questions that will come in. So
Yes, yes.
Yeah, definitely. Thank you. Thank you.
Thank you, sir. Thank you.
Thank you.
Yeah.
Good night, everyone. Thank you.
Thank you.